So welcome, everyone. Thank you so much for joining us today. I think we're going to get started. My name is Jillian McConnell, and I am the Knowledge and Mobilization Lead with brainXchange. And the webinar we're proud to be hosting today is part of a webinar series on the clinical guidelines on substance use disorder among older adults, which is being offered in partnership by the brainXchange and the Canadian Coalition of Seniors Mental Health and Behavioral Supports Ontario. So a few housekeeping items to address before we get underway. We do suggest that you connect only through your computer. You should not be on your phone for this webinar event. For those of you who do not have computer speakers or experiencing some challenges in receiving the audio, then you can join via the teleconference line that was provided in the instructions. We ask that you use only one option for audio, as using both the computer speakers and the telephone will cause some feedback or echoing. Also, on the right-hand side of your screen, you'll see a chat pod, and that's where you can communicate with my colleague Karen and myself during the presentation, and that's also where you can send your questions during the Q&A portion. If you are having technical issues, we ask that you respond back to the flyer or the invite that was emailed to you this morning as well as yesterday, and Karen will be able to assist via email. We will be leaving time at the end of the webinar for a question and answer period, and you will be able to ask your question by typing into the Q&A box that I just mentioned. Also, the presentation itself is being recorded, and the resources and the recording of the session will be posted on the brainXchange website and will be shared with you later on. At the end of the webinar, you'll also be receiving an invite to take part in a survey that can be accessed online. That should be sent to you within a day or two as well. And a link will also be posted at the end of the event, so you can have a look for that. And finally, the webinar today is scheduled for 60 minutes in length, and our presenter will speak for about 40-45 minutes or so, and then we'll leave the remaining time at the end for some Q&A. I do ask that people refrain from asking questions in the chat pod until the end of the discussion, or end of the presentation portion rather, and that way everything will be top of mind and ready to go during the Q&A. Okay, so now that the technical aspects have been taken care of, it's my pleasure to introduce our topic and our presenter. So the title of today's session is Canadian Guidelines for Opioid Use Disorders Among Older Adults, and it features our presenter, Dr. Launette Rieb. Dr. Rieb is a family physician, addiction medicine specialist, researcher, and clinical associate professor in the Department of Family Practice at the University of British Columbia. She works clinically as a consultant at the Rapid Access Addictions Clinic at St. Paul's Hospital, a CBI Health Center, as medical director of a multidisciplinary pain team, and at the Orchard Recovery Center, which is a residential drug and alcohol treatment facility. Dr. Rieb lectures internationally and is a recipient of the UBC Postgraduate Teaching Award. And on behalf of everyone on the line, Dr. Rieb, we say welcome, and I turn the floor over to you.
Great. Thank you very much. I'm very excited to be here. Thanks for the invitation. And I want to thank you, Jillian McConnell, and also Karen Parridge for all your work with brainXchange and helping to set this up. I also wanted to start by acknowledging the steering committee co-chairs, David Kahn and Kieran Rabaru, who have assisted with these guidelines. At the end of the presentation, I'll also show you our working group members. So I'm just going to, just the disclosures here is that Health Canada funded the Canadian Coalition of Seniors Mental Health through the Substance Use and Addictions Program to create these guidelines for prevention, assessment, and treatment of 4 different substance use disorders in older adults: alcohol, benzodiazepines, cannabis, and opioids. So today I'm going to present the opioids as part of the series that Karen mentioned. Working group members received an honorarium for their work on the project. I have no conflicts of interest or disclosures to make. The key messages with this presentation is that prevention works. We can reduce the risk of developing an opiate use disorder. Also, screening tools exist that are validated in older adults, and older adults do better than younger adults in treatment, so let's treat. The learning objectives for today are to list barriers to recognition of opiate use disorder in older adults. And just to note, OUD on your screen means opiate use disorder, and that will be used repetitively throughout the talk. We're going to explore the risks associated with opiate use disorder in older adults, review guideline recommendations, and there's 32 of them we'll go over, and then reflect on the guideline relevance. So what do we know about opiate use disorder in older adults? Well, we really have a number of different populations coming through. First of all, people who are aging into their older years now often were part of a generation that did more drug experimentation than any previous generation, and they have more liberal ideas about using different substances or combining different substances. We also have people who are starting for the first time with substance use in various settings, or people who have used a number of different substances and combine them and may have mental health or physical health problems. As the baby boom generation ages, we have a cohort of people who are coming through who have had more exposure than previous generations, and the healthcare system really will need to deal with that. More people are entering treatment in their older years, and more opiate use disorder is taking up a larger portion of those treatment beds. So if we look at the global issue, in 2015, the World Health Organization published a report showing that 39% of the deaths due to substance use occurred in those over 50. In those over age 65, 75% of the deaths were related to opiate use. Prescription opioids are often the substance of choice for suicide attempts in older adults, and 33% of opiate poisoning in older adults in Canada are intentional. Opioid misuse is associated with increased suicidal ideation in older adults. And if we look at this chart on the rate of hospitalization due to opiate poisoning per 100,000 across Canada, we can see comparing the 2007-8 all the way up through 2014-15. If you can see by this, this is per 100,000. You can see that the rate is highest among older adults. So the top line is those 65 and above. So you can see it's over double that of 15 to 24-year-olds. And yet what is making the media is often the younger people. We also, you can see that substance use attributable inpatient hospitalization costs due to intentional injury over age 65 with males and females due to opioid use. This is just published in 2019. You can see that it's almost 2 million in men and about half that in women. If we look at overall research on older adults, the research on opiate use disorder is primarily from the United States. We have a little bit of data in Canada, but not much. And most studies have focused on problematic prescription opioid use or those who are in and out of methadone treatment. For people 65 and above years old with opiate use disorder, there are no previous guidelines that are just restricted to those 65 and above. There's one guideline that's 55 and above, and we drew some of our recommendations from some of that literature. But there's no randomized controlled trials on medication or behavioral treatments in those 65 and above. So really we're looking at two cohorts, those long-term illicit opiate users on and off medication-assisted therapy, that's MAT on the slide, and also prescription opioid exposure later in life, developing an opiate use disorder. But most older adults with opiate use disorder start with a prescription. One study of patients up to age 75 hospitalized with opiate use disorder, 46% began their addiction with a legitimate prescription. Older adults may be involved with diversion of their opiate medication for financial gain, and older adults with opiate use disorder have higher rates of comorbid mood, post-traumatic stress disorder, hepatitis C, human immunodeficiency virus, and chronic pain, which increases the cost of care, especially those who are vets. Older adults with opiate use disorder appear to be twice the risk of death compared to younger adults who have opiate use disorder. So what's the prevalence of opiate use disorder in older adults? Past year prevalence of opiate use disorder in older adults in the U.S. is 0.8%. There's a higher lifetime prevalence, but that's past year prevalence. In Canada, it's really not well tracked, and there's inadequate diagnostic identification and coding by healthcare providers often. The estimates are that almost 44% of Canadians over 50 have used a prescription opioid, among whom about 1.1% are daily users. And there's only one study that approximates the DSM-4 drug use disorder diagnostic criteria in adults, and that's 0.5% of the population. Key barriers to identifying and caring for those who have opiate use disorder is the stigma. Some older studies in older adults show that they'd rather buy illicit opioids than get a diagnosis of an opiate use disorder from their doctor. Privacy concerns, if you're living with family or you're dependent on a caregiver, not wanting them to know about this. There's gender, race, and class issues. White upper economic class women are the least identified. There's masked symptoms of depression, grief, dementia, medical comorbidities, and practitioners have been undertrained. And there's therapeutic nihilism among practitioners, often thinking that, well, they've used it this long, they're old, why bother to try to intervene now? So how did we come about with these guidelines? In terms of method, our literature search, we looked at existing guidelines, we looked at meta-analyses, literature reviews, randomized controlled trials, and cohort trials. We searched the Cochrane Library, Embase, Medline, PsycInfo, PubMed, and other resources. And we used the Agree-To tool to identify guidelines that were of sufficient quality to inform our guideline development. Then we made recommendations based on grade, looking at the categories of evidence and strength of recommendations. And we made recommendations confirmed by consensus of our 8-member working group, and we drafted recommendations set out and sent it out. Then once we clarified our wording and agreed on it, we sent it out to reviewers and got feedback and modified it. We made 32 recommendations total, and they'll be released in the next few months in published format. So what are these recommendations? So we'll start first with prevention. The first recommendation is that older adults with acute pain in whom opioids are being considered should receive the lowest effective dose for the least potent immediate release opioid for a duration of 3 days or less and rarely more than 7 days. The grade quality was moderate and the strength was strong. This is based on the understanding that unintended long-term opiate therapy, the biggest risk factor for that is often the length of the first prescription being a long prescription or the number of pills being given out being high. So it's not to say that longer prescriptions can't be done, but people need to be reviewed, and the lowest effective dose for the least amount of time needs to be used in order to offset unintended long-term use. The second recommendation is that in most circumstances, avoiding prescribing opioids for older adults with chronic non-cancer pain, for severe pain not responsive to non-opiate therapy in patients with a history of substance use disorder, without a history of substance use disorder and without active mental illness, a trial of opiate treatment may be considered and discontinued if function does not improve or if adverse effects arise. And this recommendation is made with the understanding that non-opiate therapies are equal to or better than opiate therapies in most situations, but that there will be those who do need a trial of opioids, but that clinicians need to be on top of if function is not improving to be able to get people off so that they don't have these long-term unintended use. More recent studies have looked at efficacy with opioids, and usually only about 1 in 3 to 4, and in some literature up to 1 in 7 to 11 actually have efficacy for chronic non-cancer pain. For prevention, again, our next recommendation is that patients and their families should be advised to store opioids safely, never to share their medication, and to return unused medication to the pharmacist for disposal. The grade quality is low and strength of recommendation is strong. The next prevention strategy is that pharmacists and nursing staff are advised to inform the prescriber if there are concerns with co-prescribing, adherence to treatment, or intoxication. Grade quality is low, strength is strong. Again, involving the team can help build identification and help with earlier intervention when problems arise. The next recommendation is that in older adults with polypharmacy or comorbidities that increase the risk of opioid overdose, the lowest effective opiate dose should be used, and tapering the opioid and or other medications should be considered. The grade quality is moderate, the strength is strong. Again, trying to intervene and keep risk low by adjusting polypharmacy. Again, under the prevention section, the next recommendation is that once the decision is made to reduce the opiate dose, a slow outpatient tapering schedule, for example, 5% drop every 4 to 8 weeks, is preferable to a more rapid tapering. A faster taper schedule may be attempted under special circumstances of medical need if a treatment setting with medical supervision is available. The grade quality is low, the strength is weak. The next recommendation is that dispense naloxone kits to anyone using opioids regularly for any reason, chronic non-cancer pain or an opiate use disorder, and train household members and support staff on use. The grade quality is low and the strength is weak. Next recommendation includes skilled pharmacists and or nurses on teams to educate patients on appropriate opioid and other medication use. Again, grade quality low, but strength is weak. And the next prevention recommendation is in older adults with or at risk for opiate use disorder. They should be given advice on strategies to reduce the risk of opioid overdose and information on supervised consumption sites if available in the community. The grade quality is moderate and the strength is strong. And again, this is based on adult literature. Moving on to screening and assessment. The first recommendation in this section is that older adults should be screened for opiate use disorder using validated tools if appropriate, and I've listed some there. Medication reviews and urine drug screens should be utilized if the patient is on opioids for chronic non-cancer pain or opiate use disorder. The grade quality is low and the strength is strong. So this recommendation revolves around some of the adult literature on being able to have multiple sources of information to monitor and do early intervention when problems arise with patients. The next recommendation under screening and assessment is to identify a diagnosis of opiate use disorder through completing a comprehensive assessment. In addition, a detailed physical examination needs to be done, looking for the signs of withdrawal and sequelae of substance use. Laboratory and other investigations, including urine drug tests, should be performed appropriate to the medical conditions identified. The grade quality is moderate and the strength is strong. It's quite obvious to do a physical exam and such, but sometimes urine drug screening and physical exams aren't done when medications are initiated or continued, so it's just a reminder. And in the assessment section, a full explanation of findings and diagnosis needs to be given to the patient and, if appropriate, to caregivers, and therapeutic optimism provided, i.e. hope given that addiction is a treatable disorder and that older adults, and especially older women, typically have better treatment outcomes than younger adults. This is a consensus statement by our group. Moving on to treatment withdrawal management. The first recommendation is that Opiate withdrawal management should only be offered in the context of connection to long-term addiction treatment. The grade quality is moderate and the strength is strong. Part of the reason for this recommendation is that detoxification alone in both animal and adult human models is not effective as long-term treatment. In fact, you can increase people's overdose risk by detoxifying them, as well as increasing the level of set point that they reinitiate drugs at. So really it needs to be in the context of long-term treatment. The next recommendation under withdrawal management is that induction onto an opiate agonist is recommended over non-opioid treatment withdrawal management in older adults with opiate use disorder. If a trial of tapering is attempted, there should be the option to go on longer-term opiate agonist or antagonist therapy. The grade quality is moderate and the strength is weak. This is because no trial has been done in older adults on this topic, but there's strong evidence in adults, both for using opiate agonist therapies to help withdrawal management, and also if people are having trouble coming off or they're starting to relapse, then really they need to be stabilized on agonist therapy. The next recommendation is that buprenorphine naloxone should be considered first line for opioid withdrawal management. Methadone is an alternative that may be used, however, consider the added risk of adverse events. So there's a number of reasons that we made this recommendation, whose quality is moderate and strength is weak. This is in keeping with the recent Canadian adult guidelines that have been published, the CRISM guidelines, using buprenorphine naloxone first line. As a partial agonist, it has a ceiling for respiratory depression that may be more protective than other opioids. Also, overdose risk with take-home dosing as well is lower with this medication, so there's more flexibility. Methadone as well has a higher risk of death than any of the other opioids. Even when used in 20 milligrams or less, it has about a 1.5 increased relative risk of death. So it needs to be used with caution, especially in older adults with compromised liver effects. The next recommendation is for symptom control during opioid withdrawal management. Adjuvant medication can be used in a time-limited fashion, but with caution, since many of the medications that we use have adverse effects on blood pressure and other psychiatric effects. The grade quality is moderate and the strength of that recommendation is weak. Now we're moving on to treatment, pharmacotherapy. Buprenorphine maintenance should be considered first-line pharmacotherapy for the treatment of opioid use disorder. The grade quality is moderate and the strength is strong. Some of the same reasons apply that we just talked about. As well, buprenorphine, as well as having a ceiling effect for respiratory depression, is a full mu agonist when it comes to pain relief, so it can be very effective. There have been studies like Daitch in 2014 showing when you opiate rotate a patient with chronic non-cancer pain who is on 200 milligram equivalent of morphine up to 1,000 or more, you opiate rotate them over to buprenorphine, they can have a 50% reduction in pain. Also, the kappa antagonism effect of buprenorphine may act as an antidepressant. There's some early evidence to that effect, and there's clinical trials ongoing with that right now. Also, buprenorphine maintenance has been shown to be non-inferior to methadone maintenance at appropriate doses once people are initiated. And so for medication, the recommendation here is strong. We do have the understanding that there is more risk of precipitated withdrawal, so it needs to be done with a clinician who is knowledgeable, and there may be circumstances where it's contraindicated. The next pharmacotherapy recommendation is that buprenorphine maintenance treatment may be considered for those older adults who cannot tolerate buprenorphine or in whom it has been ineffective. The grade quality is moderate and the strength is strong. Certainly, methadone maintenance we have the most evidence for in all of the literature for opiate use disorders in adults, and the longitudinal cohort studies of adults who have aged into their older years. We have the most data on methadone of any opiate agonist therapy. The next pharmacotherapy recommendation is if renal function is adequate, daily witnessed ingestion of slow-release oral morphine may be considered with caution for those older adults in whom buprenorphine and methadone have been ineffective or could not be tolerated. Careful supervision of initiation onto short-acting morphine first is recommended prior to transition to maintenance with long-acting 24-hour formulation. Grade quality is low and strength is weak. And again, this is a cautionary recommendation. There will be only select patients who qualify for this, and just like with the adult guidelines, we really recommend that this be in a witnessed format. So not all patients will be in a situation where they can either go to the pharmacy or have someone else supervise their medication. The next recommendation in pharmacotherapy is for older adults with opiate use disorder for whom opiate agonists are contraindicated, unacceptable, unavailable, or discontinued, or who have established abstinence for a sufficient period of time. Naltrexone may be offered. The grade of that recommendation is moderate and the strength is weak. And this is based on adult literature, since there's no older adult literature with naltrexone. This recommendation is in keeping with the CRISM guidelines for adults, but we've extended it to also recommend that once stabilized on oral, that injectable naltrexone be used. It's a monthly injection. Currently, it's not readily available in Canada, but we're hoping that through putting this guideline out, this will help bring this product onto the market in Canada. Similarly, on the last slide, when we talked about buprenorphine, we're acknowledging buprenorphine in its various delivery methods, sublingual, monthly injectable, and even for some implant. Continuing with the treatment section, pharmacotherapy, the next recommendation is to offer medications for opiate use disorder in the context of connection to long-term addiction, mental health, and primary care treatment, where careful monitoring and dose titration can occur. The grade quality is moderate and the strength is strong. This recommendation really is looking at wraparound services for older adults, tend to be much better for overall health, as well as for younger adults, wraparound services with addiction treatment tend to help recovery. The next recommendation is to advise patients that the use of alcohol, benzodiazepines, and other sedative hypnotics is hazardous when combined with opioid agonist treatment, that slow tapering of substances to elimination if possible, rather than abrupt cessation is recommended. If medically managed by an experienced provider, detoxification can progress more rapidly, concurrent with the initiation or stabilization on medications for opiate use disorder. The grade quality is moderate and the strength is strong. Really, this recommendation was put in place in order to remind people of the need to really taper slowly with older adults in the community, but sometimes more rapid tapering can occur under proper supervision. The next recommendation is that early take-home dosing of buprenorphine may be considered, including home induction in patients who are low risk if they find it difficult to attend the office. The grade quality is low and the strength is weak. This recommendation is also accompanied by hopes that if you are going to do home induction, that there be some supervision within the home, some healthcare supervision. Next, we move on to dose and protocol adjustments that may be needed in older adults compared to younger adults. The first recommendation is to reduce the initial doses of medication for opiate use disorder, example by about 25 to 50%, to slow the dose escalation frequency, again by about 25 to 50%, and to use the lowest effective dose to suppress craving, withdrawal symptoms, and drug use, and monitor closely. The grade quality is low and the strength is strong. This is in keeping with other older adult literature for all other medications, given the different processing and time due to renal function and liver function, as well as cognitive function in older adults. Also, in the younger adult literature, opiate agonist therapy often works best if you push the dose high in order to try to get some blockade. But we don't have studies in older adults, so we have to be cautious of applying that kind of an approach to an older adult. So instead, careful monitoring and finding the lowest effective dose is what we're initially recommending for safety. Future studies may show that this is the right approach or that another approach is needed. The next recommendation is that the threshold to admit an older adult with social, psychological, or physical comorbidities to either residential or hospital care for opioid withdrawal management or induction onto medications for opiate use disorder should be lower than for a younger adult. The grade quality is moderate and the strength is strong. I think this is self-explanatory. For the next recommendation on dose adjustment or protocol adjustment, for severe acute pain that has been unresponsive to non-opiate strategies, a short-acting opioid in addition to opiate agonist treatment may be considered for a short duration, 1 to 7 days, and taper if necessary, 1 to 7 days. The grade quality is moderate and the strength is weak. This recommendation was put in place to avoid what we see in clinical practice sometimes of patients coming in who are on opiate agonist therapy for their addiction, but they've been put on all sorts of other opioids, short and long-acting, for pain reasons. Really, there's no evidence to combine opiate agonist therapy with other opioids for chronic non-cancer pain, so really it should be limited to only use in acute settings for very time-limited periods. Next, we talk about psychosocial interventions as part of treatment. The next recommendation is that psychosocial interventions should be offered concurrently with medications for an opiate use disorder at a pace appropriate for age and patient needs, but it should not be viewed as a mandatory requirement for accessing pharmacotherapy. The grade quality is moderate and the strength is strong. This recommendation is important since a lot of older adults do respond to various types of behavioral therapies for a variety of issues that they may be facing in their lives that may affect the addiction, as well as that may affect the opiate use disorder directly. However, there will be some patients who don't want to enter into any kind of therapy, or there aren't skilled clinicians available who can do some of this therapy, and that shouldn't be a barrier. The next psychosocial intervention treatment recommendation is that contingency management may be offered as part of opioid treatment programs if preferred by the client. The grade quality is moderate and the strength weak. And this recommendation is because the evidence that does exist shows that contingency management really has a clear role. but it shouldn't be a coercive thing. So it really should be as an incentive and if the client prefers. The next recommendation is that traditional healing practices used by Indigenous communities may be integrated with buprenorphine treatment to improve outcome for opiate use disorder. The grade quality is low and the strength weak in this recommendation. It's based on a Canadian study where communities in Ontario combined buprenorphine with Indigenous practices in Indigenous communities and had good success. This may be able to apply to methadone, naltrexone, or others, but the studies haven't been there yet, so we based this on the buprenorphine literature. The next area of recommendation has to do with setting. The first one is for patients with more severe or complex disorders. It's recommended that personnel or teams with advanced substance use disorder management skills be accessible to support clinicians and to enhance their capacity to care for patients in all settings. The threshold for an admission to hospital or drug and alcohol treatment facility under the care of an addiction medicine specialist is lower than for younger adults, and closer follow-up is needed on discharge to ensure appropriate community-based support. The grade quality is moderate and the strength is strong for this recommendation. The next recommendation for setting is that older adults with opiate use disorder who are admitted to hospital, drug and alcohol treatment facility, or a non-medical facility with access to medical care, for example, prisons and shelters, should be given opiate agonist treatment at the onset of withdrawal if requested, advisable within 1 to 3 days, with bridging pharmacotherapy treatment on discharge with confirmed transfer of care. The grade quality is moderate and the strength of recommendation is strong. Again, this is based on younger adult literature showing that treatment within incarcerated settings or within hospital settings is really an opportunity to get people care and get them onto opiate agonist treatment or to humanely withdraw them using agonist therapies. The next recommendation and final one, I believe, is a systems issue, that the cost of medically recommended pharmacotherapy and non-pharmacological treatment for opiate use disorder in older adults should be covered by the public health plan. The grade quality is moderate and the strength of recommendation is strong. Really, in Canada, we have not covered antagonist therapy, naltrexone, federally, which needs to be covered. We haven't yet covered injectable formulations of both antagonist and agonist therapies that need to be covered. And it's quite patchy all across Canada which provinces cover which medications. Also, there's very little coverage for the psychological therapies, be it motivational interviewing, CBT, contingency management, or supportive counseling around grief and loss and depression that often older adults need with role changes and isolation and other physical and mental health concerns. Really, these need to be covered because if they don't, first of all, it's not humane, and secondly, it will cost the healthcare system vastly more as people bounce in and out of hospital and distress both themselves, their communities, their families, and the healthcare system. In conclusion, older adults are susceptible to adverse health consequences of opioid use, and an increasing number of older adults are presenting with opiate use disorder. There's a growing need for opioid prevention, assessment, and treatment recommendations for older adults as the population in Canada ages. We hope practitioners will find this guideline a practical and useful clinical aid, and that communities at large will find it helpful as an educational resource. So again, the key messages for opiate use disorder is that prevention works. We can reduce the risk of developing opioid use disorder. Screening tools exist that are validated in older adults, and older adults do better than younger adults in treatment. So let's get rid of that therapeutic nihilism and let's treat. I'd like to acknowledge the opioid working group. My co-chair was Zina Salmon. She's a psychiatrist at McMaster University. Initially it was Mel Kahan, and he did our external review as well. We have a lot of thanks to Dr. Kahan. The working group members, George Budd, a pharmacist, Doug Coleman, who's a retired physician, also an addiction medicine specialist and family physician, Sid Fellman, a family physician and in geriatric medicine at Baycrest, Andrea Furlan, a physical medicine and rehabilitation specialist, also a Cochrane reviewer, heading the Cochrane section on pain, with lots of research in this area. Lillian Hung, a geriatric nurse with Vancouver Coastal Health. She's a nurse specialist in this area. Kiran Rabaru, who's a geriatric psychiatrist and family physician and one of the co-chairs of the Canadian Coalition for Seniors Mental Health. He's in University of Ottawa. I'd also like to acknowledge Claire Checklin, who's the director of CCSMH. None of these projects could have happened at all without Claire. Indira Fernando, who is our current project coordinator, who's been a vital assistance, and the CCSMH and its project co-chairs, again, David Kahn and Karen Brew. The Canadian Centre on Substance Use Addiction provided lots of support and research. Baycrest and the other organizations that you see listed on the screen, Bruyere, CAGP, CAMH, CGS, CMHA, NICE, Reconnect, and again to acknowledge the Fund Canada for the UAP program. And just to acknowledge that the views and the guidelines that we talk with don't necessarily represent the views of Health Canada, but they were supported to be created by Health Canada. So that's the end of my presentation. Very happy to take some questions now. Thank you very much. We had over 500 people sign up for this, and I'm very excited and hope that some of this information can be useful.
Thank you so much, Dr. Rieb. As Dr. Rieb said, it's now the time to open the forum up to questions. I see that there's a few people who have already been typing in, so we welcome those, and I'll try to get to as many as we can with the time remaining. I do also just want to mention that during the last 5 minutes or so of the Q&A, we'll be posting some poll questions. We do invite you all to take part in each of those questions because your responses help us tailor future webinars. So I'll just make a plug for those while I have you, have your attention. So we'll join in and we'll ask the first question, and then, as I said, I'll do my best to get to as many as I can. So first of all, Dr. Rieb, there is a lot of references to your different grade qualities and strengths. So can you touch on that a little bit more, just to provide some context? For example, one of the withdrawal management should be offered in the context of connection to long-term addiction treatment. So that received a moderate grade quality but a strong strength. So can you maybe just speak to that a little bit more, what that looks like? Not for all of them, but just as an example.
Yes. So the grade has to do with the evidence, how you grade the evidence in the literature, and that has to do with how the studies are done and how, and then we looked then about how that applies to our population, and the final has to do with whether it's strong or weak, has to do with how a combination of things, so not just the literature, but also the clinical experience and how applicable it is, what harm could be done by that recommendation, effects of that recommendation. So it's a pooling of a whole bunch of different factors. There are lots of papers published around how to go about these things, and we followed Gord Gitt's recommendations on how to grade literature. So there's some of that will be outlined in the publication as well.
Okay, thank you so much. Okay, we're going to keep going here. Do you refer to about drug screening? And so this particular organization is asking, in long-term care, why would we consider drug screens knowing residents are on opioids? Is this a recommendation more for just community care?
Yeah, great question. The urine drug screen, the purpose of a urine drug screen is to add clinical information to the clinical picture. So in the case of a urine drug screen, what you want to make sure is that the drug that you're giving the person is actually present in the urine. So some patients, even in care settings, can cheek their medication, spit it out, not take it, hoard it, sell it.
Oh, Dr. Rieb, you seem to be fading in and out a little bit.
Okay. I'll hold up my mic next to my mouth. Can you hear me now?
There you go. That's better. Yeah.
Okay. So, one, as I said, one purpose is to see that the drug that you've prescribed to the person is actually in their urine. The other is to see that non-prescribed pharmaceuticals and also illicit are not in the urine, because that may alter how you want to manage the patient and also alter your understanding of where they're at in their addiction. And so if they're, let's say, using an opioid and cocaine as well, they may need for you to help step up treatment intervention because they're more unstable. Or let's say you've prescribed them oxycodone, but in the urine you find fentanyl. Well, they're probably not taking just the oxy that you've given them. They may be selling it and buying something else on the street. So there's this kind of thing. As well, patients even in care facilities sometimes share medications with each other. So it's a safety issue as well as a monitoring issue. It's like the patient might tell you who has diabetes what they've been eating, but you do always check their hemoglobin A1C to see what their sugar control has been. So we have in drug screens. Now, it doesn't have to, usually the guidelines for chronic non-cancer pain is usually it's a few times a year that you might do a urine drug screen, unless you find something on the urine drug screen that is suspicious, either for them not taking the prescribed medicine or taking medication and substances that are not part of their agreement, their opiate agreement. In that case, you would then do more frequent urine drug screening. Ideally, random urine drug screening is done, but in some settings, that's impractical.
Mm-hmm. That makes sense. Okay, we're going to keep going. There's still lots of questions to go to, so thank you. This person is asking about, so she says, I have many older adults on opioids for chronic non-cancer pain who could be considered having mild opioid use disorder. For example, longer use than intended and persistent desire to continue with that usage. So do these guidelines pertain to these patients, meaning should they be offered opioid agonists rather than slow taper off opioids?
So what these guidelines, the withdrawal management section, are for people with opiate use disorder. So the patients that you're talking about who may be in a gray area of unintended long-term use, those you have to use clinical judgment around. If they simply have some physiologic dependence whereby they have some withdrawal symptoms if you take them down quickly, but they don't have any other flags for addiction aside from this tolerance and withdrawal issue. So let's say they've never, they don't double up on their medicine, they don't use it to mood alter, they don't binge on it, they don't double doctor, they don't have it in combination with a whole bunch of other drugs that are dangerous, they don't sell their drugs. Let's say that none of those flags have occurred. They just are on longer term than appropriate, or longer term than intended. Well, then they would fall more in the chronic non-cancer pain section, and just a slow, gentle taper would be used. Now, sometimes opiate rotation and then tapering is an easier route to go anyway, but certainly that's not what we're talking about here. We're talking about people who have frank opiate use disorder that these guidelines apply to.
Okay.
And in the prevention section, certainly trying to keep people's doses down is important. Now, we also want to acknowledge that if you taper too quickly, there have been people who go to the street to get medications or drugs because they're in such pain or in such withdrawal, and we certainly don't want to precipitate that. Also, there will be some legacy patients who have got so tolerant and who've been on 5, 10, 20, 30 years of high-dose opioids that even very small tapering we won't be able to get down. But it doesn't mean that we shouldn't attempt it. We should try to very slowly get them as low as possible within the low-risk guidelines. But some patients, we have to acknowledge we're not going to be able to get there. And in those cases, there are things to do, check to do overnight oximetry or a level 3 sleep study. If they have sleep apnea, they do need to come down. If they don't, then that's maybe a little bit more safe. Look at their renal function and their liver function. Make sure they have a naloxone kit in the house, that others are aware of what's going on if they're not sedated. These are all things that could, that may go into some reason to keep some people on higher doses if you have repetitively tried gentle tapering and it's not been effective.
Thank you for that. That's great. Okay, so we're going to keep going, and with talking about tapering or alternative medications being available, one of the questions we had was about Suboxone. Any comments about the use of that?
Yes. So Suboxone is one formulation. It's a trade name. It's one formulation of buprenorphine. So everything that I said in the guidelines, both for withdrawal management and maintenance therapy that had to do with buprenorphine, Suboxone applies to that.
Okay. Thanks for that clarification.
So there's also the month-long injectable form is Sublocade. So it's a form of buprenorphine. There's also a form that is an implantable form. So all of these forms are coming online in Canada. And there may be other ones that come over time. So we didn't want to name one type of, one trade name in case there are other types that come on board over time.
That makes sense. Another question we had was with respect to patient education and whether there were any favorites of yours or through the members of your group that was focusing on the opioid use about handouts that patients that you would use or recommend people use to educate patients about the risk of opioid use in older adults or for older adults?
Yes, thank you for that question. The CCSMH is going to make patient handouts as part of these guidelines. So we'll have prevention handouts that will cover these issues.
Great plug for them, and yes, it's on its way hopefully in the next little bit, but it's great to have that education piece, so that's wonderful news. Another question that was asked about was about patient partners and whether any patient partners participated in this particular initiative.
Yes, Doug Coleman was a patient. He was he's our community representative. He was a patient, and he also was a physician and addiction specialist. So he actually was an excellent person. We were very lucky to have someone who could provide all sides of the lens. Also, we have presented these guidelines with some of our other community partners who have looked at them as well.
Okay. And we had another question. I know I'm changing gears on you, Dr. Rieb, so you've been great in fielding all of these coming at you from various forms. Another question was with respect to the distribution of this plan, if you will. So is there going to be a bit of a rollout within primary care? Are pilot sites going to be engaged, or pilot programs, that sort of thing? Can you speak to that at all?
Well, we have the CSMH has a knowledge translation team that's been formed around all of the substance use guidelines. So there will be, as we talked about a minute ago, there's going to be handouts and flyers and things like that available. There's going to be mail-outs. There's going to be publication in the Canadian Journal of Geriatrics or some such thing. That will be a supplement that will be for distribution, and then people who are looking at these topics also, if they search Medline, will be able to see them. There may be, there's presentation at conferences. We've presented already at preliminary work at the American Society of Addiction Medicine, the Canadian Society of Addiction Medicine, the College of Family Physicians of Canada, the CCSA conference, geriatrics conferences, et cetera. So we're rolling out in this fashion across Canada and the U.S.
Thank you. So one of the questions that was brought to my attention actually in advance of this webinar, but someone provided it to me, so I think we have a bit of time to get to that, was navigating opioid use for seniors that are in a, quote, stable palliative phase. So they have chronic pain, but their life expectancy is definitely shortened, but their end of life may only come maybe coming in a year or two. How do these guidelines fit sort of that scenario?
So again, we look at these guidelines are primarily targeted for people who have addiction. They have full-blown opiate use disorder. Now the prevention section of these guidelines, in order to prevent opioid use disorder, that section might apply. However, you have to take into consideration, like you said, if it's palliative, if people are in their last 6 months, year, 2 years of life, if they have a full-blown opiate use disorder and things are out of control, things are chaotic, there's problems within the family, et cetera, it's affecting their physical and mental health, then you would want to treat as per these guidelines, because you do want quality of life even in your last year of life. If they've been on just stable medication and what we're actually talking about is just someone who's opiate tolerant, again, you have to pace it to the disease state and age of the person. But what we do know is that the caveat to that is that even in people's last year or two of life, if their opiate dose is such that they're sedated or that they're cognitively confused, sometimes it's quite amazing how people can wake up if they have a slow, gentle taper down. Often people's opiate dose, a lot of it has, if they've been on for many years, has to do with tolerance. And if you very slowly taper, people can often get on 50% or 25% of the dose you've had them on for many years, and they can cognitively clear. So you would try that in a gentle fashion. If things dysregulate, then you would go back to finding what their stable dose is. But what you're looking for, again, is increasing function, maintaining quality of life, and not increasing pain too much. So if most patients, when tapered down or off opioid medication, can have the same or pain improvement because of opiate-induced hyperalgesia, which is a whole other area that we haven't really talked about, how opiates not only can relieve pain but can cause pain. So many patients can be tapered down and have better cognitive function. However, if they're in the palliative state, you need to be careful of that. And some patients actually need a dose increase if they have disease progression, let's say cancer or other disease states that are very problematic and very painful, which there's numerous ones, but if they're in the palliative stages of that. So, you have to use good clinical sense as well.
Thank you so much. So I think, unfortunately, we need to end our time together now. We've hit the 1:01 mark officially. So I do want to say thank you all for joining us. Of course, I wish to thank our presenter, Dr. Launette Rieb. Dr. Rieb, it was just such a pleasure hearing from you today and having some time with you to share your insight with us, particularly as it pertains to these new guidelines, because they are new and they're something that we've never done before in Canada. So it's very exciting. Also, I do want to thank my colleagues from CCSMH as well, who are also on the line and have, as Dr. Rieb said, have been participating in this process from the beginning and will continue to do so. Thank you all to our participants for your wonderful comments and questions. I know I say this often, but it always makes for a really successful webinar when there's lots of interaction. So the links to the slides and the recording will be available soon on the brainXchange website if you're interested in accessing more information later on. And as mentioned in the introduction, you'll soon be receiving an email that will encourage you to take part in an additional online survey from the CCSMH. I also just wish to thank again CCSMH and Behavioral Sports Ontario for their financial support for this webinar series, as well as BSO's Substance Use Collaborative, which really led to the development of these best practice guidelines. And as I mentioned in my introduction, this webinar is the second in a series regarding the new clinical guidelines of the substance use disorder among older adults. So please keep your eye out for information on the next webinar, which is likely to take place in the next month or so. So if you're a brainXchange member, you'll receive notification with the registration for that when the next event opens. So once again, thank you everyone for their time today and also taking part in the poll questions and the feedback. That's wonderful. And I wish you a good remainder of your day. And till next time, goodbye everyone.